Now go on to our next talk on phakic IOLs in high astigmates and keratoconus. Again, I don't think Dr. Kumar, doctor needs any introduction, is a very dynamic, versatile cataract and refractive surgeon and director of the KUMAR Eye Institute at Mumbai. And with great experience in the refractive surgery of a couple of decades or more. I shouldn't say more, that makes him older. So on to you, Dr. Kumar.
Thank you, Chitra. I don't like her courses because she gives you the topic and then you have to start scratching your head. So she had added one more thing in this which I conveniently deleted, which was saying phakic IOLs and penetrating keratoplasty. I have experience of none. So I decided to remove that topic from my main topic and keep only two things which I have little experience about.
Keep it for discussion.
Okay. So there's been a great evolution over the number of years and decades. Things have come and gone, changes, and I feel the future in refractive surgery will be surface and smile. Only two things will survive test of time, and I think LASIK flaps, yes, will continue, but not as much. Femto flaps will continue, but blade will be going out. I just want to discuss one case or two cases, and I'll show the slides. This was a 25-year-old diagnosed with keratoconus, both eyes. I still do C3R and Intex. I don't do so much of TREC. No worsening of vision, no change of refraction over the number of 2 years. Corneal topography showed no sign of progression and demanded spectacle-free vision. So the patient had minus 1.75 at 5.5 at 612 and minus 1.25 at 6 at 145, 612. So this is after Intax. Of course, it was a cone which was inferior. After Intax, it did stabilize a bit to some extent and it was quite stable. Pachymetry, as you can see, is 477. White to white is 11.7. ACD is very good, 3.22. And this is after Intax again. You can see the centralization of the cone, which is very, very good.
Timer should be checked, please. Should not be informing you for it. No, you carry.
Okay. So we had a lot of options here as to what we can do. We could have done lots of things. I decided to go ahead and do a phakic IOL. So the central cornea, we know the high order aberrations. Most important is stable refraction and stable topography. So we had this for almost 2 years and no other issues. And this was the pre-op. So you can see post-op, I got a patient with a minus 0.5 and a 612. So aberrations, and you can see the root mean square is 0.38 and root mean square high order aberrations is 0.08. So that's the reason why I decided to go ahead and do a phakic IOL. This is an OCT picture of the same. I had a very good vault and everything looks good. Coming to previews, about a lot of presentations have happened all over the world, and now this is quite an accepted fact that if it's a decentered cone, we can do Intact, centralize the cone. You have a good ACD, patient wants spectacle freedom, then you can go ahead and do an ICL, which is going to do very, very well. Coming to phakic toric ICLs in high astigmatism, this is quite a normal thing because if the astigmatism is high, it's quite possible to do this. But the big advantage I feel why this should be considered is because we're not touching the cornea at all. So all the risks of corneal ectasia are completely gone. It's a reversible procedure. So if the patient develops glaucoma, cataract or anything, we can just remove the ICL. Improved post-operative result. The quality of vision is far better because if you have a thin cornea and you have a high astigmatism, you need to keep a larger optical zone to prevent regression, and you're not going to be able to do that. So if you keep a smaller optical zone in a high astigmatism, then again the results are not very good. There is some amount of regression that happens in such cases. So corneal aberrations are stable, risk of regression is averted. So there are lots of advantages of considering a phakic IOL in such cases. There are enough presentations over the number of years. It's quite time tested, so it's not anything new that we are doing, and it's quite proven. So this is again a 22-year-old stable myopic astigmatism, almost at 12 months, uncomfortable with contact lenses and wishes to have. So 8.5 and 2.25 and a 521 thickness definitely is not going to be eligible for any other refractive procedure. And a white to white of this keratometry was done. We do measure white to white. This is the pre-op topography, and the ACD was 3.12. So even if you have a high astigmatism with high myopia, this is the other eye, again an ACD of 3.11, 8 with 2.25 and 11 with minus 4. So this patients will 100% do very, very well with a phakic IOL. So if you have high astigmatism with a thin cornea, you can do this. Now, what I do is still marking. A lot of people use Virion. You can still use Virion if you have it. There is nothing wrong in that. again the placement can be done. Once that is done, we can double check if necessary sometimes, and that's how I do the marking to make sure that we are right. And sometimes also mark the incisions. There are two ways I always inject the methyl. You can also do irrigation through the side port and put the IOL inside BSS itself and remove the step of washing at all. So here I like to inject in the same axis. You can see this is a plate haptic design, which is like the star design with a central hole, and we align just the marks that is necessary. So high astigmatism this is just 10 degree of placement, so there's not much rotation from the 180. Once one side of the plate goes behind, the other side of the plate goes behind. Any methyl cellulose I like to wash with Simcoes, the old our favorite Simcoes, and that you can even go beneath the lens. I just keep irrigating and it just keeps flowing out. If you want to avoid this, Gaurav injects ICLs under irrigation itself. I've tried that, but somehow I was not very happy because I was not having control, and sometimes the patient feels the pressure of the water. I don't know, Gaurav will like to tell us more about injecting ICLs under irrigation itself and nothing else. So sometimes I'd like to press the ICLs to remove the methyl from behind, and you can even go behind the ICL, just irrigate fluid and that will remove all the methyl. Of course, we give acetazolamide post-op for 3 days, and that controls the IOP quite well. So as far as toric ICLs in high astigmatisms with a 11 with 4 with a AIOC2022 does give excellent results. So as far as my experience with Intacs and ICL is very, very good, and of course ICLs per se is very good. I have some experience with Trek, but it again has some limitations. So in the past I used to do without Trek. I used to just remove half the amount of refractive error on the cone and then treat the rest. So as far as keratoplasty, I'm just going to show why it should be considered post-op astigmatism. Of course, high anisometropia between the two eyes. There are some articles published. So I have zero experience in this. I've never done this, but this is just some articles published that phakic IOLs are very effective in high correction because of DALC or any other procedure the patient has undergone, and of course has a very high amount of astigmatism. So this has been published over time, and it is proven that it works quite well. So multiple studies have evaluated safety, efficacy of implanting in post-keratoplasty, bearing in mind that certain patients do wear contact lenses is an option for such patients, but there is a risk when you wear contact lenses in such cases. Thank you all for your attention.
Thank you. I would definitely take 2-3 questions. One very simple question I'm going to ask Shreyas. Can two patients with the same white to white have different sizing of ICL?
You mean different sizing as in our measurement or the IOL size?
ICL size. ICL size. Yes.
There are the factors are white to white and anterior chamber depth. So whether it's a very deep anterior chamber depth or a shallower anterior chamber depth, you'll have to choose it accordingly to the
and
white
also
to white.
the corneal curvature could have been different. So even if the white to white were the same and the AC depth,
Curvature won't affect.
Curvature will not
factor
affect,
at
it's
this
the
point of
ACD,
time.
but then if you're doing, if you're using the same online formula and you use the white to white and the ACD, for the same refractive error and white to white, you can have different lenses depending upon the ACD.
ACD, not on
But
the
if you're using UBM, again, it can be it depends upon what is known as the lens rise. So how much is the lens equator above the line connecting the ciliary sulcus to ciliary sulcus. So that can also influence the sizing of the ICL.
It'll influence the final vault. So
Vault,
you have any
a quick question on the phakic IOL in KC, sir. Do you feel centered versus decentered cones? Does it make a difference?
Yes, big difference.
So you don't
Even
do
it will be the same application in even IOLs.
correct, sir. No, but you say a strict no in decentered cones.
Strict no.
I would do a no. I would do an Intacs single
No,
ring.
I'm talking
then-
about
No, he's-
topo guided or Intacs, but now patient is stable and this thing. Do you feel topography
always
should be a greater?
More than topography, I look at the best corrected vision. If the best corrected vision is better than 612, then you can go ahead with an ICL. If it's 612 or worse, I don't go in with an ICL, I probably do an Intax or a topo guided and followed by an
Even
ICL.
with a rose scale lens on top of
No,
it.
that if the BCVA is poor or
Poor,
best
yeah.
spectacle corrected visual acuity is poor. We just did a recent analysis, sir, of 150 eyes where of keratoconus patients. Though this was not the research question we were looking at, but on a post-hoc analysis when we were looking at data, there were cones which were centered, cones which were decentered, but with good best spectacle corrected visual acuity. And we did not find any difference in outcomes, residual power, astigmatism, whether it was centered or decentered, as long as the best spectacle corrected visual acuity was repeatable, the refraction was repeatable, and patient was happy with that best spectacle corrected visual acuity. Definitely better than 612 like sir suggested.
But I agree with what your analysis may be, but I'm looking at long term. So these patients ultimately will develop a cataract, okay? And when they do develop a cataract, to have an Intax inside sometimes is better than to not have an Intax inside. The reason being, a central cone in a cataract with an IOL will perform very well. So I've had a decentered cone in a VVIP. I suggested a 72-year-old keratoconus. I suggested Intax with IOL over time, right? They went because they're big donors to a very big institution in South India, and obviously 72-year-old was not suggested to have Intax, obvious for reasons. It's not going to progress, the cone is going to be stable, and suggested I do only an IOL, and the patient is not happy. So point here is that I have had patients where I've done Intax that centralizes the cone, the quality of vision improves, as you said, the best corrected, and then go ahead and doing an IOL is a much better strategy.
And for decentered cone, I would prefer Intax over TopoLink, because TopoLink
100%.
works better in axial cones
Yes.
than decentered cones.
Yes.
Just a quick point, sir, because in cataract and phakic IOL are a little different, because in cataract we don't know what the exact BCVA is. I mean, what has gone down because of the cataract.
Yeah.
BCVA is-
So if the patient had a poor best spectacle corrected visual acuity before the onset of cataract, they would still be dissatisfied after the cataract surgery. Whereas with our keratoconus patients, we really know what their best spectacle corrected visual acuity is, what they are likely to get. So I think that way IOL, I agree that it might be a little unpredictable. And in an earlier cornea session, we were discussing the same thing, that for a toric IOL, unless its keratometry is repeatable and consistent, we would not even consider a toric IOL, put in a spherical IOL and ask the patient to wear contact lenses post-op. But otherwise, for KC patients, I mean, I'm not saying Intax is not good, sir. Intax definitely can be done and can be used. But previously, we had this notion that slightly decentered cones avoid phakic IOL altogether. But now seeing that as long as the best spectacle corrected visual acuity is good, the patients are able to accept.
In your
That's
study of
because
these,
more than decentered or axial, it depends upon the morphology of the cone. If you have an MS39, it gives you the morphology of the cone. Looking at the morphology of the cone also will determine how much the best corrected vision would kind of be there after a particular procedure. So it's
the
not only the
morphology again-
centration, decentration, the morphology of the cone, how the cone is a nipple shaped or a different kind, there are different morphologies. So depending upon the morphology, that would influence the best corrected visual acuity. So apart from just decentered and centered.
so MS39 is a machine, some of you might know, it's sold by Schwind, but only question here was, even if you do a morphology, you it's made by CSO and it's calibrated, it's linked to Schwind also now.
Okay.
So the point here is, even if you get the morphology, you have a decentered cone, say inferior cone, best corrected is say 618, 612. I don't know that if you do an ICL in this case without doing Intax, which axis is the patient really going to land up using?
Just use the refractive axis. That's all we
Always.
do. Always.
Blindly the patient will use refractive axis.
Don't use the
Definitely
topographic
not
axis.
the topographic
Don't
axis.
do
If
Oh,
you
that
use the
I
to-
understand.
Yes.
If
That
you use
I
the
understand.
topographic axis, you will be in
No, no,
trouble.
that
Always
is
use the
in trouble.
refractive axis, best corrected vision, and then do it. If it's better than 612, patient will be happy. If it's 612 or worse, he will be unhappy.
Then better to do Intax.
But yeah. Anyway, I hope people do change their thoughts about what they're doing rather than